Dr. Barbara Wise. She's actually in town and visiting with us, so I want to get an opportunity for everybody to meet her. So why don't you tell us a little bit about yourself?
Oh, that's a long story. Where do you want me to start? Well, I'm a psychiatrist. I've been specializing in geriatric psychiatry for over a decade. Yes, I am that old. But I've practiced in lots of different settings: military medicine, military psychiatry, community psychiatry, ER psychiatry, inpatient. I currently am doing nursing home work in North Carolina, and then I'm also serving here in Texas to kind of help supervise our behavioral health practice with Psychiatric in the number of facilities that we go to.
So actually tell me a little bit about your background. So how you kind of came into the nursing home world and all that. It's kind of interesting story.
The nursing home world, I think it was sort of a organic feeling for me. We were talking about organic. It started because my grandmother was in the nursing home. And I remember that when I was a young child, feeling very helpless to intervene for her because she had had a series of strokes. And my mom would go visit her every single day. And back then it was, I'm not gonna tell you how long ago that was, but it was not a good place to think about spending your life. And I think unconsciously that kind of created a drive for me to improve things for our older folks, particularly in nursing homes. And so when I was in my training for psychiatry, I developed an interest in specializing kind of in geriatric psychiatry and focusing on that older age group. I can go in there and talk to families, talk to patients, talk to staff, and really get a whole picture of what's going on with the patient and trying to minimize the harm that sometimes medical professionals inadvertently do. We don't like to touch each other's medications. So one doctor will start something and then people just keep adding things. And so I like to go in and look at everything and try to minimize the things that are causing more problems and maybe leading to some of the psychiatric manifestations, as opposed to just continuing to add more medications.
Well, and I think that's one of the big things that we really try and look at Psychiatric is we're trying to marry sort of that behavioral health side with the primary care side so that we're working together to improve the health of these residents. But I think one of the misconceptions a lot of people have too is that people in nursing homes get, I think the term that a lot of people use is like snowed, that they're sort of in this sort of transient state where they can't really interact or do stuff, and that we use medications to subdue their behaviors and sort of put them into that snowed state. So why don't you kind of talk about that a little bit and how that misconception sort of, you know, got started, or what we're doing now to make that different?
Yeah, and I think there was basis for that misconception for many years, because I think people are not well equipped to deal with some of the signs and symptoms that develop as people have cognitive problems or late life depression, late life anxiety, insomnia. And so to try to ease that distress, people will sometimes use inappropriate medications or higher dose medications. And I think it was a thing that we used to do because I think our medications weren't very good at one point. And so I think that led to a lot of that kind of idea that people were over sedated. But my goal is actually to get rid of those medications. Sometimes, unfortunately, people do have symptoms that can be dangerous to themselves or to others, and we have to use medications, usually temporarily, to kind of calm things down. But then we adjust things and try to get people to a better place. I'll tell my patients that I want you to feel comfortable in your body. I want you to feel comfortable in your skin. And that is whether you're young or old. But I also talk to my patients about the fact that a lot of times they never intended, when they looked at themselves at 20 years old, you never intend when you're 80 that you're going to be in a nursing home. But sometimes that's where your life is, and it's a big adjustment. And some people have an easier time adjusting than others, and I think we can support them by, like you said, marrying the medical with the psychiatric, using therapists and medication management folks who sort of understand that difficulty that older adults can sometimes face.
Well, and I think one of the things too that people need to understand is not all nursing homes or long-term facilities like assisted living, unfortunately, not all of them have psychiatric coverage. So I think that's a newer concept. I think for a long time it really was sort of the primary care doctor, and honestly for a lot of years the primary care that was done in the buildings was literally people who were clinicians that had a clinic and sort of as a side time. They weren't really fully devoted to this space, and so they didn't have specific training in psychiatry, and I think they were just sort of trying to use what medications they felt like they had that might control a behavior or something that was unpleasant for the staff at the home to deal with or other residents to deal with. And I think the practice one of psychiatry has come a long way in general in the last few years with new medications, new kind of approaches and things, and really looking at reducing medications. But also just some homes really are fortunate, and I think if people are looking, if you have a loved one that suffers from a mental illness or dementia that's up there, I think it is important when you're looking at facilities to ask the question, do they have psychiatric coverage specifically in the building?
Right.
So, because not all of them do, and I think that's an important component, especially if you're looking at a memory care unit or somewhere where you're going to have a lot of residents that are probably going to have behaviors. Because even if your loved one isn't exhibiting behaviors, if you put them in that memory care, other residents could exhibit behaviors towards them.
And I think the other thing, one of the misconceptions is that we don't understand why this patient's going to develop behaviors associated with their dementia or their neurocognitive disorder versus another patient. We're still trying to understand what causes it, where it comes from. And unfortunately, a lot of the medicines we use are off-label. And we have to be very careful and judicious in what we choose. And if you don't sort of practice in this space, I think you have a tendency to use maybe too many things, higher dosages and that sort of stuff. And so that's why I think it's important, like Laura says, to find a facility that kind of addresses that in a unique way. And there are ways to do that, whether it's with a psychiatrist or a psych nurse practitioner. We also have a physician assistant that has specialty kind of psychiatry training. So I think those are good questions to ask when you're looking at different facilities.
And I think too, having the counseling portion that we have too helps too with trying to work with the patients and also with family members on kind of bringing them to a level of acceptance of what's going on and where the patient is going. Each patient is unique and individualized, but over time, I think a lot of us have so much experience, we can't tell you the exact course a patient's going to take, but you start to kind of see the signs and symptoms that you can at least give the family a fairly good prediction of what's going to happen.
Well, and end of life issues are hard for us all. None of us want to think about the end of our lives and the shortening of our lives, but having that conversation, whether it's with a medical provider or a mental health provider, and kind of helping you reconcile, what do I need to say to my loved one at these last phases? Are there things that I, wish we could have done, or if I have memories I want to explore? And even those that are cognitively impaired can engage in that in some level and kind of maybe help ease as you say goodbye to your loved one. I think that's really important, and it's hard to do.
Yeah. One of the things I've seen more recently, and kind of see if you've seen this too, I've seen a lot in the memory care units where you have couples, because patients are living longer and going with the disease and progressing longer. Spouse gets to where the other spouse can't care for them at home. They put them in the facility, they're in a memory care unit, and the patient is functional, meaning they're ambulatory, they can move around, they can feed themselves if you set the plate in front of them, but they really can't tell you their spouse's name any longer, they can't name their children. And one of the things I've seen that family members have really struggled with, an example is we have one assisted living where the wife is actually the patient, the husband's there. The wife has really attached onto another male resident that's in the memory care, and the husband is having a really hard time because he's like, she's married to me, she shouldn't be holding his hand, she shouldn't be, snuggling up to him. And we keep trying to explain that cognitively she doesn't know, she doesn't remember, she's not retaining, she doesn't have the same memories he does. And so trying to get him to a place of acceptance with that. And I think that's a hard issue to deal with when the family wants, I want her to not touch anybody else. I want her to be just like this.
Yeah.
And he comes every day to visit her.
Yeah.
And every day she wakes up in a new world and doesn't remember who he is. She doesn't have that. She would actually prefer to be with this male resident than with her own spouse, because she really doesn't recognize him at all, but she does. And that male resident is consistently there,
Right.
and they really believe that they're married, actually, I think. And so it's
Yeah, I mean, I have seen that, and I've also seen where one partner is more impaired and they both go and live in an assisted living. And so it's an adjustment, like for them both to live there or for one of them to live there. But as far as what you're talking about, I think not only acceptance, but there's lots of phases of grief, and it is kind of a prolonged grief reaction. And so kind of talking with families, it's denial, bargaining, depression, anger, family members can go through all of those sorts of phases. And sometimes educating folks, there's a number of books, like an Alzheimer's book, it's the 36-hour day, can be helpful, because it sometimes can help people understand that what they're going through, they're not the only one going through it. And kind of this idea that I haven't failed them, I'm not a failure, I've not,
right.
Yeah.
But I think one of the other things that's really difficult for family members to understand or accept is, I've known Mom, she was very straight-laced, very strict growing up, but now Mom's like disrobing and she's cussing, and so it's like this person that they don't even, it's hard for them to put that together.
Yep.
So,
and I wish I understood that, but we don't know enough about the neurobiology behind what leads to what's called BPSD, which is the behavioral and psychological symptoms of dementia. We don't know, and that's what you're describing, whether it's they used to be this way, and then once they develop neurocognitive disorders, they have agitation, aggression, psychosis, the disrobing like you're talking about, and
cussing or yelling,
and
being aggressive,
screaming and hitting, and they're like, this is not my mother. And you're right, it's not your mother, it's not your mother's brain, and unfortunately we don't quite understand that process that's going on in the brain, and we don't know how to stop it. Certainly lots of studies are going into how to diagnose it better, how to predict it, how to control it, and that's where research is headed. But it's just hard because folks with dementia, it's hard to consent them for some of the studies. So
Right.
our studies aren't great. It's more like case reports or kind of case series of this is what, and it's kind of clinician experience. So the more you see it, the more you kind of develop a way of handling it, because the studies aren't there to tell us how to treat it and how to take care of it.
Have you seen over time, I would say I've seen over the last couple of years, I just want to know your experience, of facilities really trying to focus on doing some extra training for non-pharmacological interventions for patients, like redirecting, trying to get the behaviors?
Yeah. So if I had to look back over my career over the last 10 years, I mean, deprescribing and decreasing antipsychotics, it started with antipsychotics, and now in the last 5 years, it kind of got broadened from the government to essentially try to deprescribe every medication, every psychotropic that a patient is on. And along with that, if you're deprescribing, you have to have something in place, and that's going to require staff education, non-pharmacologic interventions. I mean, I document non-pharmacologic interventions every single time I see a patient, whether it's redirection, reorientation, physical activity, reapproach. There's even measures, if you have patients that are going into other patients' rooms, they're not supposed to, put a black mat on the floor and it looks like a hole. And a cognitive patient won't walk because they'll think they're going into a hole, Or one of my favorite stories is I had a patient that kept using the bathroom in the closet. And and I was sitting in the room and I was looking at the room, and there was the bathroom door, closet door. And I'm like, well, they don't know which doorknob to grab, right?
So they're just grabbing.
So right, they were right. So we got one of those knob things that you use for kids, and you have to like clutch it to open it. We put those on the closet doors, and guess what? She was going in the right room, in the door, in the right because she couldn't open the other doors. So little things like that, you can sometimes identify ways to kind of
Pictures.
intervene.
I've seen where they use a lot of pictures to say this is your room when they go around.
Right.
I keep asking.
And people will respond to stop signs, like when they're going out exit doors. If there's a big stop, there's almost like some sort of trigger to that red sign. They know what that means, and they'll turn and go the other way.
And I think kind of last thing I want to talk about, just what are your thoughts? You know, everybody keeps talking about COVID and what we've seen. I know we saw a lot of increase in anxiety, depression, isolationism, kind of through it when families couldn't visit their loved ones, and now facilities are starting to open up, but on a limited basis still. So most of the time you have to have an appointment to come in and do that. What kind of effects have you sort of seen from all of that?
It took a toll. I think that the isolation and separation from families, it led to, and not only that, but the measures that the facilities had to put in place to limit resident to resident spread. They were staying in their rooms more, staying in their beds. I think it led to more debility, depression, yes, anxiety. I think to some extent it may have shortened some folks' lives. Certainly I think medical comorbidity probably went up. I know that, you know, the facilities that I go in, it was noted that our antidepressants did go up, even though I was still able to reduce anxiolytics and antipsychotics. There were more folks that they were still struggling, and it was really hard to do any kind of deprescribing. I was seeing patients probably more often because they didn't have the outside support and the outside engagement. So the therapist and I would see people sometimes once a week, twice a week, whereas sometimes we, you know, pre-COVID, it would be every 4 to 6 weeks. But during COVID, we offered more support just so they would have some sort of interaction and engagement.
Yeah, I think we're going to see kind of the effects over the next couple of years, really what happened during this time when they do some retrospective studies and they're able to look back and just kind of see what happened during this time frame. But I know on the scales, the depression was substantially rising during it just because of all the feelings of kind of being isolated and
that's what patients would tell you too, that, you know, I feel a lot worse just because I can't see my family. It was, and they would get more confused. And,
and lack of activities too, because usually in the building they had like the bingos, or they had people coming in to play music. Like everything was.
I know.
Stopped.
It was really difficult. It's been really difficult because we haven't fully opened in North Carolina where I live. I think Texas is a little bit more open, but North Carolina is still pretty locked down. So
they're still struggling a little bit.
Yeah, it's still taking a toll.
And they didn't even for a while, they weren't even letting, like, you couldn't get food delivery. Like if you tried to order outside food, they wouldn't let it come in. So
the flowers sat outside the facility in this little anteroom for 3 days because, you know,
so they're basically dead by the time. Here's your nice expensive flowers.
So much for that. I'm not sure, but yeah, it was kind of sad actually.
So what are your thoughts, just to kind of wrap things up, like where you think psychiatry's headed in long-term care?
I think psychiatry is a hot field. I think there's more and more nurse practitioners who are training. I don't think there's more and more psychiatrists, but I think the way that the field is heading is more kind of mid-level nurse practitioner PA support, because there are not enough psychiatrists. So it's gonna be one doctor kind of supervising multiple different nurse practitioners to kind of help care. And honestly, that's the way that I can exert more influence, because there's no way that I could take care of as many patients as I do unless I had support from mid-level providers. And
but here's a controversial question. We'll ask it because this is like
controversial.
Yeah, this is controversial. So in a lot of states, NPs and PAs are now completely independent. So how do you think that's going to affect like somebody who just and everybody has thoughts on this, and I know that pretty much all 50 states now are going to be going to allowing the independent practice of nurse practitioners and physician assistants because once several states did it, they actually won some lawsuits, and so it will be happening even here in Texas pretty soon. But I do think there is a difference in saying someone who's been through all the medical school and residency and training versus someone who does, you know, a 2-year, and I don't want to say 2-year program because generally nurse practitioners, not generally, nowadays they have to have their BS and then they're doing their RN, getting that, and then getting their NP. But overall, the training is different. It's not saying necessarily one's better than the other, but the plethora of experience with one is different than the other. And so I think there is going to be some issues with brand spanking new NPs and PAs who don't have that, who go off on their own immediately.
Yeah, and I think it is a tricky, controversial kind of question, so thank you for asking it. Obviously, I think MD-leveled providers learn more. We do go to more school than nurse practitioners and PAs. And there are differences in how good one program is compared to another.
Right.
There's some that do a lot more rigorous coursework and a lot more clinical work and stuff. So I think there's differences. I think certainly there are some patients and certain age ranges and simplistic, more simple diagnosis, straightforward, not a lot of history, that would be easier for particularly new psych NPs to take care of, or PAs. But there's going to be plenty of patients that are going to be challenging.
Well, and I think so much of what we do, like I think over time, I think you develop, what do they say, like experiences, a whole lot of what we do too. You learn to recognize things because we always it's kind of a running joke that we say patients don't read the textbook. So a lot of times they don't present exactly the way you think they're going to. And so a lot of that is just the experience of having seen it before, dealt with it before, and recognizing it. Right. And so an example I use from the primary care side is I've had patients before that came in and had, you know, young nurse practitioners that were just getting out, and they're like, what's wrong with this child? And I'm like, oh, it's chicken pox. And they're like, well, it doesn't look like the textbook. And I'm like, but they were vaccinated, so even if you were vaccinated, you can still get it, but it presents a little bit different. You don't know it till you've seen it a couple times, and then you're like, oh, okay, that's what that is. So experience is a lot of it, and I think over time you get a feel for what you're doing. But I do think it's still important to, when you have a loved one in a facility, one, make sure if they do have substantial psych history or substantial dementia issues, that you are putting them in a facility that will provide them with psychiatric services. But I think it's important to make sure that there is supervision that's somewhere available or higher up, not just one independent person, or at least find out about the background of those people that are going to be caring for them. Are they brand new to this? Have they been in the field a while?
I think making mid-levels independent practitioners is kind of a necessary evil, because it sounds kind of bad, but because there's not enough MDs, and there are certainly a lot of patients who aren't getting care because they don't have access to a physician. So I understand the idea behind it, but I think you're right that, and most mid-levels that I engage with and talk to actually do want some level of guidance and supervision in the first, at least in the first few years. Because I certainly get lots of questions. I have a practice I supervise in Tennessee that's PAs. And a couple of them are almost brand new, and they have tons of questions, you know, because they've never seen it, they don't know how to go through it, and, you know, we meet and talk, and I think at some point they will need less of that. And I think that would be true of any mid-level provider, and it really is a personal thing, because some people are very good at reading and going to meetings and asking questions, and they see lots and lots of people and they learn really, really fast, and other people learn slower. So I think overall it's a good thing, but it's something
I think that the residency program for physicians gives you more of an opportunity to have experiences and exposure to academic settings and resources that they don't always have. That gives us a longer stance of establishing that for when we get out. So
I agree.
So any parting words of advice for people who are looking at facilities for a loved one that, you know, maybe they have behaviors, maybe they don't, maybe they just have memory issues. So
think it's good to visit facilities and talk to people that work there and not just go by star ratings. There are some facilities that are very, very good and yet don't have super high star ratings because the government star rating is based on some arbitrary factors a little bit. So don't just dismiss a facility just because it looks like it may not be good according to what the government says. I would encourage you to kind of go in and visit it, take a look, tour it, talk to some folks that work there, and you'll get a feel whether people are happy there, whether they like their job, and if they like caring for people and like taking care of people, particularly older folks, and they kind of get a laugh and they enjoy their residence, then you'll be able to tell. And I think that's important.
Yeah, definitely. I think looking at the calendar, seeing the activities that they have planned, seeing the things, and I think
calendar's
the other
up to date.
Yes, the calendar's up to date. And then also just kind of, I think sometimes people also think if it's new, it's nice. Just because something is new doesn't mean it's the best program. So,
Right. That's true.
or the safest. So sometimes new places don't have staff that have really worked with a lot of people. So don't be afraid to look at some of the older buildings too that have really established, because some of them, we have some facilities here in San Antonio that great programs, older buildings, but they're locked facilities because they're scared that the patients are going to wander out or roam, and they actually do really, really well at giving the patients a lot to do and things like that. So, okay. Well, thank you guys for tuning in, and we will see you next time. Thanks.